in that particular movement, the intra-abdominal pressure wasn't managed quite optimally, and we saw quite a bit of kind of coning. So is that necessarily a problem? Not necessarily, but potentially, if that was done on a repeated basis, that could theoretically maybe overstrain tissue that's becoming a little bit more fragile and spread out theoretically, right? So these are things that we just want to be thinking about to mitigate that unnecessary repetitive strain without making people feel really fearful that they can't do things, right? Is that okay? So the piece that I always like to finish as soon as they're lying down is I just want to check the thorax just in one more way. Again, this is pretty global, to get a sense of if there are any potential restrictions here that might sort of limit how optimally we can get the pressure managed, okay? So I start off literally just hugging, and it's a gentle just side to side motion. I sort of come down until I'm at those lowest ribs I can reach. So generally that felt pretty good to me, right? I wasn't being too sophisticated, but you will be surprised how obvious it is when someone's not moving there, even when they looked like they were moving beautifully and sitting, right? And we can kind of see it quite a bit, okay? So likely you guys will find that when you're practicing, okay? That seems pretty darn good to me, so I'm happy with that. So then we move on to the next piece, which is the external technique to see what's happening with the pelvic floor. So really we think about where the pelvic floor attaches and trying to get purchase on those areas that don't have a lot of other tissue around them, so we can feel like we're getting as isolated a palpatory touch to that muscle as possible, right? So one way is by simply having our finger right at the perineum, right? So that is the midway point between the tailbone and the pubic bone, that midway point where the perineal body is. To really be able to kind of get the best sense there, it would be advised that the client would maybe have their underwear on still, maybe they're draped with a sheet, you have gloves on, and you're putting with firm pressure there to see when they engage, are you feeling the tissues lift away from your finger, and when they relax, are they coming back in? So that might be one way. If that even is a little bit too sort of up close and personal for the way you do your practice, then we can try to get on to just medial to the ischial tuberosities, right? And see what happens there. So again, you can get onto this in the same crook lying position. So you find this can be a bit of a pokey technique, okay? So you find that ischial tuberosity, so it's right here, right? And then once you're on that point, then you just slide your finger kind of medial and cranial, right? Do you know how to contract your pelvic floor? Do you think you do? Okay, so I want you to go ahead and do a pelvic floor contraction when you're ready. Okay, and then let go. So I could feel that right away, right? So that's an option. Another option, same thing in this position, you can kind of hook on, come onto the tailbone, and then slide your finger just lateral to it, and same thing. And I tend to always have my hand here, so I'm feeling, are they actually doing a Valsalva? Does it seem like obliques are coming on really dominant when they think they're doing a gentle isolated pelvic floor contraction? So I tend to just always have my other hand here gently. When you're ready, go ahead and contract again. Good, and I can feel that beautifully and let go. Okay? So then what I'm feeling is actually the tissue kind of moving up and away from my finger. Okay? Okay, so then I think, great, she knows how to do the pelvic floor contraction because she needs to be able to do that, or a correct TA contraction for the tension generating test, right? So I want to make sure I have all that cleared first. So the first piece I do, and of course when someone's pregnant, we're not going to be quantifying this the way that we would do sort of postnatally. This is more just getting principles. We're dealing with a moving target. It's hard for us to diagnose pathology when the linea alba is supposed to thin out and spread through pregnancy, right? So to kind of be labeling dysfunctions during pregnancy, that was something that in our consensus work kind of came out that really that's probably a misguided way of doing things. So certainly we can kind of garner information in terms of what's happening, be as proactive as we can about teaching people to use optimal strategies, but in terms of labeling things on people who are pregnant, like how appropriate is that, okay? So that's what our experts said. So we start off with our integrity check. So in this case, we have a little bit more space compared to the last participant I was doing this on. So we start at the top of the linea alba. I tend to always use just 3 of my fingers just really tissue. So you're just sinking down all the way until you can kind of feel that end feel, right? And really you want to feel a consistency that's like a trampoline, right? So we want tissue to be responsive, but to have that tensegrity and an actual end feel. You don't want to kind of touch here and it's so taut and tight, because tight, taut tissue doesn't work very well, right? So it needs to kind of be in that Goldilocks position, right? So this actually feels pretty darn good. So then I'm literally just going to go to the next little spot, do the same thing. I literally go to the next spot. So here I can feel that it's noticeably has less strong of an end feel, right? It feels like if we were saying that up here it's almost like it's 3 pieces of reinforced saran wrap, it might only be like 2 here, right? There's a very subtle sort of difference. Again, we don't necessarily make too much of a conclusion about that, but we're making note that, actually it does seem like the tissue in this little chunk seems to have slightly different consistency to here. We saw when she did a reverse sit-up that there was some things happening there. So that might be a useful thing to just do some education about, just to make sure we're managing pressure, right? The next thing we do is now we check, and then I kind of stop, because where the baby is and the uterus is hard, like you can't really discern much from that, right? So you kind of go until it sort of makes sense that there's nothing in behind you kind of really biasing your results, right? So then I would say, okay, now I want to see if at this spot, and where I tend to do these other 2 checks, which is their tension generation capacity and what is the interrecti distance. I tend to do those at where it seemed like the integrity was the least, because that's where there likely is going to be, if there's sort of an issue, that's likely where it's going to be, right? So in this case, I would do it right here, right? Does that make sense to you? So now I want to see, okay, I know she can contract her pelvic floor beautifully because I already checked that. When she does that, is there some connection here, right? So when you're ready, go ahead. Good, so I do feel a little bit of it there. So then I'm thinking, okay, great. Maybe if the integrity of the issue is a little bit more obvious, and then I check this and I'm not feeling much of a connection, I might creep up to where it seemed like her linea alba was good, have her contract again, and sometimes you'll see, yeah, okay, interesting, I can feel it connecting here, but not in that integrity spot. Okay, so that's giving you a little bit of info in terms of, yeah, we might have some things to do maybe once she has the baby to help to kind of reestablish that, right? And then last but not least is the interrecti distance. So again, I come back to that spot. I tend to always start with 3 fingers, and then if I need to go down, I go down, and if I need to go up, I go up. There is no really standardized protocol. I find that this works well for me, okay? So I'm gonna come here. So when you're ready and you're not gonna be contracting your pelvic floor or anything when you do this, you're just gonna lift your head and shoulders up off the table, or off the bed, so the ground chair. Good, come on back down. Okay, so in that case, I actually have to add just 1 more finger in, okay? So go again. Good, and back down. So she's probably just over 4 fingers there. So it's important that you capture that measure as soon as she starts to lift and you feel that activity in the rectus. That's when you capture it, because the more they come up, the more those tissues are going to automatically narrow, and you're going to get a false read, right? We're trying to get sort of a baseline sense of where things are at, not where things are at with high-level recruitment of rectus. Does that make sense? Okay, any questions about that before you guys go practice these things? And everything I've just covered is there's slides in your books about all of those things, okay? Is that okay? Yeah. So a group can stay up